The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone. The webinar will start very shortly. We'll just give it 2 minutes just so attendees can come in, but we'll begin very shortly. Thank you. Okay, so we'll begin now the webinar. So welcome everyone to this SPR webinar. The Communications Committee of SPR is very happy to have this, which is the first SPR webinar of this year. My name is Alex Vaz, and I'll be your host for today. And we're very happy to have today's webinar being held by Sibel Halfon from Istanbul Bilgi University. She'll be presenting to us on assessing children's affect regulation strategies in psychodynamic play therapy. And before we start, I'd just like to briefly introduce to you the webinar tools. The first webinar tool is to raise your hand and ask a question. You should be able to find on your dashboard on the right side of your screen a hand raising button. So this is to indicate that you have a question. If you indicate that you have a question, I'll open up the microphone to you and you can ask a question directly to Sibel once she tells us that this is the time for Q&A. If you don't have a microphone or prefer not to ask your question directly, you can also type your question in the questions tab on the dashboard that's also on the right side of your screen. We'll have time for questions and discussion at the end and during the talk. When Sibel finds it most appropriate, she'll indicate that to us. So without any further ado, Sibel, thank you so much for having us, and please go ahead.
Thank you so much for having me. Everyone can hear me well, I hope.
I think we hear perfectly.
Okay, great. So I'll first start by introducing myself just a little. I'm an assistant professor at Istanbul Bilgi University in Turkey. I primarily teach in the child and adolescent track of our clinical psychology department on psychodynamic theory, technique, and supervision. So we also have an outpatient psychotherapy center in our department that's run by our professors and our interns. And we practice psychodynamic treatments informed with mentalization principles. And one of the major aims of our treatment with children is enhancing their mentalizing and affect regulation capacities over the course of treatment. We emphasize the importance of working with underlying disruptive emotions. This could be aggression or other negative emotions, and their regulated expression and representation within a safe therapy relationship. So this is the context of my research within this naturalistic setting. My research focuses on psychodynamic psychotherapy process with children, primarily with internalizing and externalizing problems. And I'm particularly researching the development of mentalizing and affect regulation capacities of children over the course of treatment. Just so you have a picture of our research setup, I'll tell you how we collect data. Initially, patients come to our center, and after they apply for psychotherapy, some of them consent to participate in research. And in that case, separate research meetings are conducted with the parents and children by trained research assistants before they begin treatment and at the end of therapy, where we administer symptom scales and other functioning and mentalization measures in order to assess pre- and post-treatment change. Also, all our psychotherapy sessions are videotaped and transcribed, which helps us study the in-session processes associated with changes in treatment. So we particularly code selected sessions from different children for in-session mentalization adherence and affect regulation in play by trained outside coders. And in fact, that's the coding that I'll show in this webinar. I'll explain in detail how we do the in-session affect regulation coding. And then I'll briefly mention the research that we do with it so that you can see its applications as it relates to mentalization processes. Okay, so why affect regulation? The reason we focus on affect regulation is externalizing and internalizing problems have been related to negative emotions and affect regulation difficulties in many studies. Children with internalizing and externalizing problems often have difficulties with play, symbolic play, and particularly with regulation of negative affect and its representation. Internalizing and externalizing children show different affect regulation strategies. Even though they both have problems, externalizing children show low levels of emotion regulation and high impulsivity. Children with internalizing problems are more rigid in their emotion regulation strategies and over-control their emotions. Also, both disorders are related to extreme negative emotions. In particular, research shows that anger is more related to externalizing problems, meaning children with externalizing problems show anger-related issues, whereas more dysphoric affects such as fear, anxiety, or sadness are more linked to internalizing symptoms. Therefore, overall, improving affect regulation capacities is a major aim in psychodynamic child psychotherapy. Okay, so how do we assess this? We investigate in detail the affect expression and regulation strategies using the children's play therapy instrument. On this slide, you see every item and every scale of this instrument. It's a very wide instrument that's psychodynamically informed, and it aims to assess the child's play activity in psychotherapy. It has various indices, so you can look at the categories of play, how the child facilitates play, the relational aspects of play, the coping defensive strategies in play. I won't go into every item or every scale. I'll just show you the affect items for this webinar. But if you're interested, Sarali Shazam, one of the developers of the measure, has multiple publications detailing the different scales. With the CPTI, you can use it to differentiate the play characteristics of children with different diagnoses. You can also use it to systematically track the children's play processes over the course of treatment to see if there is any change in their play styles. In our case, we're going to try to see if there's any change in their affect regulation strategies, hoping that there's improvement. Okay, on to the coding now. But before we start the coding, I'll just show you. There, on the left part of the slide, you see a scale named segmentation. We code affect regulation in play because we're doing psychodynamic play therapy, and we look at how children express affect in play. So we first have to segment the session into non-play, pre-play, play, and interruptions. And only play segments are coded. Then, in order to generate an affect regulation score, we code the play section of the session for affect items. Okay, so before starting to coding, I will first show you a video of a child, the first session of this child with externalizing problems, so that you have a sense of, what the sessions look like. And I'll actually use this example of this child to show you how to do the coding while I walk you through the specific affect items. So this is a 5-year-old child who came to our center with a psychiatric diagnosis of attention deficit hyperactivity disorder. His problem behaviors were rule breaking, impulsive behaviors, restlessness that ended up in serious injuries, difficulties going to sleep, and also difficulties with separations, especially from his mother. Okay, so this is the first session of this child. I'll start the video.
Geldi. Uyuyarak mı? Diyerek. Uyuyarak. Farkında olmadan neler yaptı bu adam? Ne vuruldu şimdi de? Diyemedim. Aşağıda. Aklıyor, kendini izliyor. Ama yine açık neden koydu beni? Kendi de içeride ne miydi? Bombalar patlıyor. Bulamadı. Her yerden bir teknik. What you get?
Of a session, the first 5 minutes.
And I got it.
Sorry. Okay. So the first item in the affect, so CPTI has children's play therapy instrument, which I'll call CPTI from now on, has 4 affect structure items. I'll first introduce them and I'll walk you through scoring this case example. Our first item is regulation and modulation of affect, which assesses how easily different intensities of affect are expressed within the child's control, scored on a range of 5, which is very flexible, to 1, very rigid. And when coding this category, it's good to ask yourself these questions. How does the child show different intensities of the same affect? For example, let's say one moment child is annoyed that he can't find the toy he wants. The next moment he starts to tantrum and can't stop himself. So this is clearly a child who can't regulate his anger and it escalates beyond his control. So then after the child shows intense affect, is the child able to modulate the affect to return to equilibrium? For example, a child gets so angry that he starts hitting the therapist and is unable to calm down unless he leaves the room. This is a child who can't modulate his anger. So let's look at the actual scoring. We rate affect regulation on a scale of 1 to 5 using the following criteria. We give a score of 1, which is very rigid, when the child's feelings rise so suddenly, he or she can't calm down, ends up showing very extreme feelings or tantrums. He or she is stuck in that affect state and gets disorganized. Or alternatively, the child is so constricted, they show no affect and is flat throughout the play. We give a score of 2, which is rigid, when the child's feelings rise relatively suddenly and he has difficulty controlling his or her feelings. Though this may not lead to tantrums and very severe disruptions, we still look for significant agitation within the play narrative. We give a score of 3 when the child has moderate control over his feelings. Even though he or she does not completely dismiss the feeling, he can also at times show difficulty sustaining it. Alternatively, he or she may also get stuck in that feeling state and keep going back to it over and over again. Despite disruptive feelings, he or she can continue the play. We give a score of 4, flexible affect regulation, when the child has considerable control over feelings, does not get stuck in one intensity or stay away from a difficult feeling. Even though there may be 1 or 2 occasional disruptions in play, the child is mostly in an optimal range. A 5 is when affect regulation is very flexible and the child has full control over different intensities of a feeling that gets expressed without disruptions in the narrative. Okay, so in the example that I showed you, we see that the child's feelings rise very suddenly and he has little control over his feelings. The child character he plays enters the castle sleepwalking. Not quite knowing where he is, his first instinct is to throw himself off the tower. He loses balance several times, cannot find safe ground, is in constant motion. These are suddenly followed by extreme aggressive acts like bombing and blowing up the house. So he's showing a general lack of safety, hurting others, himself, an increasing sense of danger. And he's only able to control himself by burying away the aggressive feelings, which are symbolized by a gun. So a rigid affect regulation would be appropriate for him because his feelings rise very suddenly. He switches from one feeling to another. He can't quite control the feelings. There is no tantruming, but there's quite a bit of disruption. In terms of the second affect structure item of the CPTI is transition between affective states. Here we assess how the child organizes transitions from one affective state to another. Is it abrupt or smooth? Scored on a range of 5 to 1. Again, when coding this category, it's good to ask yourself this. Can you follow the transitions in the play narrative, or is it so sudden that you ask yourself, what is this child playing? We rate on a scale of 1 to 5. We give a score of 1 when there is always abrupt transitions, when the child moves manically from one feeling to another. It's like a turbulence of feelings. We give a score of 2 when there's abrupt transitions, when the child still moves considerably fast from one feeling to another, even though he may just stay in one feeling state for a little while, but the narrative is still disjointed. A 3 is when the child fluctuates between feelings, meaning it's possible to follow the child's feelings with more ease, but there is still fluctuation from one state to another without a fully coherent narrative. A 4 is when there are smooth transitions. Feelings expressed follow one another most of the time in a more coherent narrative. And a 5 is when there is very smooth transitions. Feelings expressed are quite easily followed within a coherent narrative. In the case of the child in the example, his transitions between feelings are quite abrupt. We see anxiety, a sudden impulse to want to throw himself off the tower, then a general dizziness, then we get a little dizzy, then showing feelings of hurt, unsafety, followed by aggressive, dangerous acts. So he moves from one state to another very, very fast, and it's hard to follow him. So a 1 would be appropriate here. The next affect structure item of the CPTI assesses the spectrum of affects, meaning the range of emotions in the child's play. It can be very wide, he or she can show a lot of emotions, or constricted. So this is a fairly simple item in that we identify the feelings and then count them to give a relevant score. So if the child only conveys one emotion, then the spectrum is constricted. If the child conveys 2 or 3 emotions, the spectrum is narrow. If 4 emotions are observed, the spectrum is medium. If 5 emotions are observed, the spectrum is wide, and it's very wide when there is more than 5 emotions. So the child in our example shows a medium range of emotions, primarily anger. There is fear, hurt, and also pleasure. So we see, I'll just identify the emotions for you. We see extreme anger in the form of bombing, killing, destructions, and we also see this in his statements and nonverbal acts, like the bombing sounds he makes. He does not show very overt fear, but there is a fearful theme of throwing himself off the tower, knocking into places, which we presume is associated with a fearfulness and a sense of unsafety. We see moderate pain as the character hurts his foot, and the child also emotes that. We also see that he enjoys the aggressive acts, like calls himself a hero, seems to take pleasure while playing the bombings and the fire. There's a smile in his face. So we give like, we identify 4 emotions, we say a medium spectrum of affects. The final affect structure item of the CPTI is appropriateness of the affect to the content, which assesses, as the name implies, appropriateness of the emotions expressed by the child within the context of the play team. Are they always appropriate, a score of 5, or never appropriate? So we give a score of 1 when the child's feelings are never appropriate to the play team and there is a large disconnect. This happens mostly like with very, very traumatized children and gives an eerie feeling to the observer. We give a score of 2 when even though the child can at times show congruent affect, it's most of the time disconnected. A 3 indicates sometimes appropriate emotions to the play content. A 4 is given when the child usually shows appropriate affect, and 5 is when the child always shows appropriate affect. So in the example of the child, the feelings that the child shows are mostly appropriate to the play team. The play team involves danger, confusion, aggressive acts, wishing to be very powerful, but seeking limits. And the feelings we identified, anger, pain, fear, pleasure, are congruent with that. At the same time, there is a very slight disconnect in that he's doing quite scary things and not quite showing overt fear. Is more in dissociated states or in a mode of dizziness, like sleeping or not quite knowing where he is. So there's a slight disconnect there. So I would give him a 4. So overall, when we look at the affect structure of this child, he gets a 2 from affect modulation, a 1 from affect transitions, a 3 from affect spectrum, and a 4 from affect appropriateness. He also shows significant anger, moderate hurt, and mild anxiety or fear, as well as pleasure. Okay, so this is basically how the coding works. What I'll do now is I'll show you another video, and I'd like everyone to try to code the video, this second example case for affect regulation, affect transitions, affect spectrum, and affect appropriateness. And then we'll discuss this video, and then I'll open it up for questions. So this is a remarkably different child. This is a 7-year-old girl who also came into our center with rule-breaking problems. She was demanding, obsessed with money, constantly wanting her parents to buy her things. Okay, so let's look at the session.
Kalıyor mu? Çıkarken kalkabilir. Selam. Tamam. Tamam. Hala. Hay Allah. Kum koyunca ayağım ne kadar zor şuruyor. Evet. Evet. Ayağının olacağı yeri kum kapladı. Hayır. Bu büyük. Bu küçük olduğu için. Ha, ayakkabı küçük olduğu için. Sen kaç? Kaç kilosun? 33. Oo. Ayakkabı küçük olduğu için.
Okay, now what I would like you to do is, I'll walk you through the scoring again, but please note down any discrepancies that come up between my scores and your scores so that we can discuss the questions that come up. It's only possible to understand this coding through practicing and through comparing your scores with mine. When we look at our affect regulation strategies, this is a child who shows many obsessional defenses in the form of wanting to fix the sand, making it straight, messing and tidying up, taking in and removing things. Therefore, we should keep in mind that generally her affect structure is constricted. In terms of her affect regulation strategies, we don't see affects rising beyond the child's control, nor significant agitation, as we saw in the previous child. But she still can't let go of her preoccupation with how much she has or lacks, how tidy or messy the surrounding is, how big or small she is, and repeats the same thing over and over again throughout the play narrative. possibly due to underlying anxiety. So we look at our scores. We would give her a moderate affect regulation in that she keeps going, she gets stuck, sort of stuck in a feeling state and keeps going back to it over and over again. We don't see significant disruptions or tantrums, but we see a lot of repetitive activity that shows over controlling an emotion. In terms of her transitions between affect states, they seem to be smoother than the child in example 1, though we suddenly find her in the sand tray as her desire to possess all the sand rises after neatly fixing the sand. Then she gets a bigger shovel to get even more sand. Then she again starts to remove what she took, fearing it's too much, and she starts the same sequence. So I would again give her a 3 in that even though we can follow the overall play narrative, she fluctuates back and forth. In terms of the spectrum of affect, it's hard to see very overt affect. Like I said, she's quite, as she says she wants to be in the sand. She starts humming to herself as she wants to get more sand. And we can possibly see some anxiety as she cannot find just the right amount to keep or remove. Therefore, her spectrum is quite narrow and she gets a 2. Finally, in terms of the appropriateness of the affective content, the affects she expresses, which are, like I said, pleasure and slight anxiety, are appropriate to the play theme, which are, the joy of taking in and keeping things and the anxiety of having too much and the need to give up some. So overall, this is a child with moderate affect regulation, fluctuates between affect states. She shows a narrow spectrum of affects and appropriate affect. So Alex, I think I'll just stop here and open it up for questions about, anything I've said until now. And then in the second part, I'll show you how to, after the questions, I'll show you how to use these affect items in research.
Okay, thank you, Sibel. We're gonna open up then questions. Let me see. There's this feedback here. Okay, I got it. So I'm gonna open up for questions. So what you can do is in the right side of your screen, there's this little hand raising button. Anyone who has questions can click on that, and you'll have your hand raised. We already have one hand here raised, and you can also put a question on the questions tab. So I'm gonna pass the microphone to Nicholas Bagatini. I hope I said your name right. Let's see if I can. Nicholas, I'm not sure you have a microphone because I can't seem to open up the microphone to you. I'm not sure why. Would you maybe like to write your question on the questions tab so I can read it out loud, please?
I'm muted.
So, Sibel, for now, I think that maybe you can proceed. Because we don't have any questions right now.
Okay, all right. So I'll show you a little bit the kinds of research that we do with these, and maybe questions may come up on the way.
Great.
Okay, so just a little bit about reliability and validity. Previous studies done by other researchers have shown good inter-rater reliability and validity. The measure is sensitive to changes in psychotherapy, and it has shown good convergent and predictive validity in relation to play characteristics of children with internalizing and externalizing problems, and discriminant validity in differentiating traumatic versus normal play. How we do the coding is in our study. So you've seen the sessions, and you've seen how the sessions are videotaped, and they're also transcribed, and you need a transcription to do the coding. Two coders independently code the sessions, and we look for at least an interclass correlation of 0.7 or above between the two coders, and usually we get good to excellent interclass correlations that range from 0.75 to 0.96. These are all, by the way, trained coders. They got 3 days of training with me and then did a reliability set, and after they become reliable, they're able to code the actual sessions. So in our studies, we use the affect regulation and affect characteristic scores in different ways. We conducted studies that assessed whether there is development in children's affect regulation over the course of treatment. And if so, we tried to identify the therapeutic processes associated with that growth. In a prior study, we investigated whether there is growth in affect regulation over the course of treatment with a sample of 48 children with internalizing and externalizing problems. You can see their demographic characteristics up on the slide. So we coded 329 sessions from different phases of treatment for children's affect regulation strategies. We found significant quadratic growth in children's affect regulation, meaning it initially decreased, followed by an increase. And this is the multi-level model. And if you look at the line most below, you'll see time quadratic is significant, implying quadratic growth over the course of treatment. We also investigate the therapeutic processes associated with that growth. Children's difficulty regulating their feelings may be related to mentalization deficits. As you've seen in the videos, some of these children have difficulty naming and representing their feelings. We see it, for example, in aggressive acts or dizziness or like preoccupation with tidiness, and particularly they have difficulties with negative feelings. In the first child, we saw difficulties with aggression. In the second child, we saw like an anxiety about how much she has, how much she can possess, how big she is, how small she is. So the way I narrated the emotions, these children also need help building these symbolic bridges between affects and their representations, verbal and nonverbal representations, to arrive at better affect regulation. So in order to enhance these children's symbolization processes, therapeutic goals in psychodynamic play therapy focus on the importance of mentalizing functions. What is mentalization? I'll just briefly describe it for you. Mentalization processes improve children's ability to label and understand mental states in self and others and connect them with behaviors, which then allows them to organize and have a better understanding of their emotional world. So in the research that we do, in order to measure mentalization processes, we use the RF prototype of the child process Q sort. The Q sort consists of 100 items which contains statements that describe the child's attitudes, meaning the child plays spontaneously, that's an item. The therapist's actions, and the nature of the patient-therapist interaction. And the RF prototype is conceptualized as an ideally conducted prototypical session that promotes mentalization, taking into account therapist, child, and therapeutic interaction characteristics. I'll show you the most characteristic items of an RF adherent session. According to expert clinicians, most typical characteristics of a mentalizing session include therapist actions that verbalize internal affects, comment on changes in child's mood, and make links between child's feelings and experiences. Therapeutic interaction characteristics that show sensitivity to the child's level of development and accommodation to the child's needs. And child's characteristics, which include curiosity and willingness to communicate in affect and engage in spontaneous play. And we hypothesized that mentalization processes in psychotherapy would be significantly associated with children's development of affect regulation over the course of treatment, meaning adherence to mentalization in the sessions would help children develop better affect regulation capacities, which we actually found if you look at the row with the red arrows. We found that in the previous sample that I showed you with 48 children and 329 sessions, adherence to the RF prototype significantly predicted affect regulation. In another study, we wanted to investigate whether children's expression of negative affect within the context of mentalizing practices in psychotherapy would be associated with gains in affect regulation. The reason we wanted to test this is, as I've been saying all along, internalizing and externalizing children suffer from global measures of extreme negative emotions such as anger, sadness, anxiety, and fear, which we also saw in the videos. And psychodynamic treatment models that enhance children's affect regulation by helping children express negative emotions in a safe therapeutic environment, in a safe therapeutic relationship, and gradually explore their links with other mental states and behaviors are generally effective. So we investigated whether negative emotion expression, which is anger and dysphoric affect, within the context of higher mentalization adherence, would predict higher gains in affect regulation. We studied 40 children with internalizing and externalizing problems and 975 sessions from long-term psychodynamic treatment. We coded each session for affect expression, which is anger, sadness, fear, and anxiety, and affect regulation characteristics. And each treatment was scored for average adherence to mentalizing principles. We found that dysphoric affect expressions such as sadness, fear, and anxiety in high RF adherence sessions was associated with higher improvements in affect regulation. So this is the statistical model we tested, and you'll see that dysphoric affect in the context of RF adherence promoted affect regulation, predicted affect regulation. So we interpreted this finding to say that the opportunity to express and explore underlying dysphoric feelings within the context of mentalization practices could be regulating. We also looked at associations between changes in affect regulation and outcome. And we found that actually children's changes in affect regulation was associated with reliable change on children's global assessment scale, which is it's the child equivalent of GAF scores in adult treatment. We also found that mean RF adherence was associated with improvements in CBCL total problems. So I've shown you some ways in which the measure can be used clinically as well as in research. Clinically, like going back to those two children that I showed you, we see that their affect regulation strategies are remarkably different, and they need different kinds of clinical interventions. Like after coding for affect regulation, you can have a conceptualization of how to do the treatment and treatment prognosis. Whereas the first child is in more need of containment of his aggression and safe boundaries to regulate himself. The second child needs help expressing her desire for more and finding safe limits around that, so that she can express herself more spontaneously and show a wider range of affect. So first child needs, briefly, just summarizing, first child needs more containment, and we see how, poor his affect regulation was. Second child has a narrow range of affect, so she needs help being more spontaneous and perhaps help with, dangerous affects such as how much she has and the anxiety of having things and perhaps the anxiety of growing up, being big, so that she can express herself more freely. So you can use these affect regulation items of the CPTI for treatment planning. And like I've shown you, you can also use it to see if there is change, if there is improvement in children's affect regulation, which is a major aim in psychodynamic therapy, and we do see improvement. You can also use it to assess, what improves children's affect regulation. And we've chosen mentalization because it's, theoretically and also empirically closely associated with affect regulation. And we found that mentalization promotes affect regulation, and particularly expressing negative feelings in the context of mentalization promotes affect regulation, which gives an evidence base to psychodynamic treatment models. So I'm going to stop here and I'll open it up for questions.
Thank you so much, Sibel.
Thank you so much, Sibel.
So again, I'd like to invite everyone, whoever wants to ask something of Sibel or comment or give some feedback, they can either do it through raising their hand on the raising hand icon on the right side of your screen, or you can leave a question written here on the questions tab and I can read it out loud. So feel free to do that now. Hello, Jupe. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes, feel free to talk.
Okay, first of all, I think the research is very impressive. I think the different categories for scoring the affect are really very interesting, very helpful, very useful. So I think it's a very important contribution to the field of affect regulation in children in the context of therapy. There are two things that I wanted to ask. First of all, I would be curious to know whether there are any measures of change in affect regulation outside of the therapy room. So in let's say in the home situation or the school situation. That's one question. And the second question is, I don't come from a psychodynamic orientation, and I wonder, I was looking at emotions as being expressed in the body of the children in the physical, in the way the children express themselves. And my concern is that maybe there's a lot of interpretation needed before you can give some of the scores. So I would be very interested in comments to these two questions.
Unmuted.
Okay, thank you so much. Really good questions. CPTI is not, the affect regulation score of CPTI is not so much a pre-post measure, it's more a process measure. So it assesses whether there is improvement in affect regulation over the course of treatment, and it's more meaningful to use that, to use the affect regulation scores as a process measure, like I did, you know, choosing certain sessions or using all sessions of different psychotherapies to look at growth over the course of treatment. But yes, there are measures of change that we use. I wasn't quite sure if you're referring to my research or in general, but we use the ERC, Emotion Regulation Checklist, by Shields and Cicchetti. It's a parent measure about child's emotion regulation outside of therapy. It assesses emotion regulation in different contexts, with friends, at home, at school. And we give this measure before treatment and after treatment to look to see if there is improvement in emotion regulation over the course of treatment, according to this measure, according to ERC by Shields and Cicchetti, which we actually find that there is significant improvement on the emotion regulation subscale of ERC over the course of treatment. I hope I've answered that question. Otherwise, please let me know if I've left anything open. Your second question is also, it's a very good question. It does require, coding for CPTI does require clinical knowledge and psychodynamic theory. It doesn't require, immense knowledge of theory, but you do need to know affect regulation characteristics and affect regulation tendencies according to psychodynamic theory. Like, what does it mean to have abrupt transitions? What does it mean to have, moderate constricted affect with obsessional defenses? So it's a psychodynamically informed measure. I wouldn't say it's not impossible to code it without psychodynamic background, but you would get reliability a lot faster if you have psychodynamic knowledge of some of these constructs. Then it's much easier to apply it to research. I hope I've answered both questions.
Jude, would you like to say something?
I would like to thank thank very much for this, for the answers to the questions. I appreciate this very much.
Unmuted.
Okay, so we have two more. I'm gonna pass the microphone here to Leila. Leila, can you hear us? And can you talk? So I just tried to open up the mic to Leila Akuru Dirani. I hope I'm saying the name right. Okay, it seems we can't hear Leila right now, so I can try later. I'm gonna try now to pass the microphone over. Oh, we have a question here, so let me read this question out loud for us. So, see. So there's this comment here saying, thank you very much for this exciting and informative findings. It's great to see that there is a link between therapist behavior, interaction, and child behavior. So that's more of a comment. I'm sorry, Nicholas. I can see you're writing here that you can't change why you're muted. I also don't know, to be honest, because when I try to unmute you, there is no sound, so I'm not sure what the technical difficulty is. But if you do want to write down your question, you can also do that. So there's here another question saying, oh, sorry, there's someone talking?
Yes, you can hear me now?
Oh, now I can hear you. Hello.
Oh, I'm sorry.
Go ahead.
Maybe I have changed something that I don't know what it is.
Go ahead.
First of all, congratulations about the research. It is very, for me, very new, because I was searching some tool to analyze the process in child psychotherapy. I came late to the seminar, so I don't know which ages are intended in the tool to be assessed.
Unmuted.
For which age?
Okay, so basically it's for any child who plays. So it's usually children between the ages of 3 to 10. It's most appropriate for. But you know, if there is a very regressed child, ages 11, 12 who plays, of course, why not? But in my research, we use it for children between the ages of 3 to 10. We find that after 10, children don't invest in play in the way that, you know, they have done before. The play space, it loses its magical quality, and, you know, they're more interested in the external world and in verbalizing things. And children below the age of 3 don't have enough symbolic play capacity for this coding. So between 3 to 10, it works perfectly. But I should say that the affect regulation scores correlate with age, meaning when you use it in research, you have to control for age. If you're looking at associations with symptoms or other kinds of functioning, usually children who are younger have more, let's call it poorer or more like abrupt affect regulation strategies. They show much more intense and abrupt affect compared to older children who are better able to organize themselves. Affect regulation develops with age. So it's good to control it in research. It's good to also look at correlations with age to see, you know, if it predicts in the way that you expect it to predict age and development. But you can use it for children between the ages of 3 to 10, I find in my research.
If I understood you well, you have to know that your patients, there is a development affect regulation issue there, and the instrument is only one instrument. So you have to control it. You have to have a control group for knowing that your patient is out of range. Did I understood you well?
Unmuted.
I'm not quite sure I understood the question.
I'm trying to be clearer. It is childhood between 3 to 10. The child's gain affect regulation from development. So, in a child who has 4 years old, having a 3 or a 2 or a 1 in one dimension is the same than in a child that has 10 years old.
Unmuted.
You're right. So, like I said, you would expect a child who is younger, below the age of 6, to have, I'm saying this, with caution. I'll use the word poor. I'm not saying, it's poor affect regulation. It will be less than a child who is above the age of 6. So it's good to either control age in your analyses, or to break up your sample to look at, if you're using a cross-sectional sample, to look at affect regulation strategies for children from 4 to 6 in one study, and to look at affect regulation characteristics of children from 7 and up, 7 to 10 in another study. It wouldn't be good to compare affect, other than, looking at differences in age, it wouldn't be good to compare affect regulation strategies of children below the age of 6 and above the age of 6 in a cross-sectional sample.
Okay. Thank you very much.
I'm muted.
I'm now going to pass the microphone, or try to pass the microphone, to Albert Ali Salah. So Albert, are you there?
Yes, can you hear me?
Yes, we can. Go ahead.
I wanted to ask about the investment in play, which you just mentioned that it's more in children who are smaller than 10 years old. Is there any control about the amount of digital media usage for the children? And if there is, does increased digital media usage like tablets, cell phones, etc., signify a decrease in the investment of play?
Unmuted.
Okay. That's a good question. It's a question for research. Yes. We don't quite, assess how much children invest in digital media in this research. So we don't have any data on that. I'll just speak from my clinical knowledge and intuition. I find that some children are unable to enter into that play space, and they prefer digital media, or they prefer the structure of the digital media more. The play space and the spontaneity of the play space may sometimes become scary for them. Just using their internal world to express in play may become too much for them, or they're too constricted and are unable to show that in play. Digital media might be an anchor. It might also be an escape from, expressing their internal world. So it would be actually very interesting to get a scale of, how much they engage in the digital media before treatment, and to see if their investment in play varies according to that. I'm sure it would. I'm sure, like, children who invest more as an escape, or because they're scared to show their internal world in just the spontaneity of play, would use the play space differently.
That's really interesting. So it's in theory should be possible to design interventions that are completely in digital environment in that case, but they have to be fine-tuned for this.
Absolutely, and actually, it would be a great intervention. It would be like a stepping to play, like on the ladder. Let's say, play. To be able to play is a capacity. To be able to bring the internal world into the unstructured play space is a capacity. To invest in play is a capacity. Some children, and children with clinical diagnoses, have difficulties with that. So the digital space could actually be an anchor for them to enter into the play space. It could be like a stepping stone, so that they can, use the digital space first, and then perhaps use the more unstructured, spontaneous play to express themselves. It could be a great, therapeutic intervention, and it could be a great, treatment planning idea.
Thank you.
Thank you. We have Sandra here, Sandra Raffman. I'm going to try to open up the microphone, which I'm not able to do, but I do have a written question here. So by Sandra, she writes, thank you for this very exciting and informative findings. It's great to see that there is a link between therapist behavior, interaction, and the child behavior. I don't know if you want to comment on this, Sibel, on this link.
Unmuted.
Oh, on this link.
The link between therapist behavior, interaction, and child behavior. Could you repeat the comment for me?
Yeah. So she just says it's great to see that there is a link between therapist behavior, interaction, and the child behavior. And there's also a continuation to this previous comment. Sandra writes, I wonder if you see other ways to see the link between the therapist's sensitivity and responsivity and the child's regulation other than through mentalization. There's a lot contained in the RF adherence measure.
Unmuted.
No, absolutely. I mean, RF adherence is one way of conceptualizing therapist sensitivity. One drawback is it doesn't quite, play also happens in the nonverbal space. Child's behavior, especially for children below the age of 10, happens in nonverbal space. So it would actually, be very interesting to assess therapist sensitivity in terms of nonverbal cues to child's affect, how much synchrony there is between the therapist and the child, how much mutuality there is between the therapist and the child, how much the therapist tracks the child's affect and emotes accordingly, which are all nonverbal indicators, which I would presume would, highly contribute to the child's capacity to regulate affect. So I would code nonverbal behavior, which you can do with, more affective models that assess nonverbal behaviors of the therapist and the child, their synchrony, and how it affects affect regulation.
Okay, thank you, Sibel. Let me read you another one we have here from Sandra Artar. So she writes, thank you very much for sharing all this valuable information that we can incorporate both into research as well as clinical use. My question is on the range of affect subscale. Do we have to concentrate on the affect shown by the child or the range of affects that we can interpret as a therapist? For example, with the second case example, as a therapist, it was possible to interpret and define the anxiety lying beneath the obsessive behavior, but I'm not sure if the child herself expressed or showed anxiety.
Unmuted.
That's a great question. It's because this is a research measure, it's best not to be too inferential. But it's a psychodynamic measure, so there will be some inference about the clinical work that's going on, and it's best used with some clinical intuition, but not too much. So there should be something overt. In this case, like I said, we saw pleasure clearly. In terms of the anxiety, it was mild, but the fact that, she kept going back to, how much she had to remove, taking in, taking it off, and the repetition in that could be associated with anxiety. I can't say for sure, that's why we get inter-rater reliability. I would, in that case, because of the amount of repetition, code for anxiety, and because of how much the child goes over the same behavior over and over and over again. So you can do some clinical inference, but it's best not to do that too much so that, there is reliable coding.
Thank you. We have a question here from Leila, and she writes, in terms of effectiveness, more effective in externalizing or more internalizing problems, the best age?
Unmuted.
The best age? I couldn't hear.
Leila, would you like to clarify the question? Would you like to clarify the question? I'm not sure we totally understood it. If you want to write down your question again. And while we're waiting, we have a question here from Francesca. She says, I'm sorry I missed a part of the lesson. I would like to know, how did you assess the mentalization functioning during the treatments, and how did you select the sessions in the study with Bulut in 2017?
Unmuted.
So, for the first question, for mentalization adherence, we use a measure called child process Q-sort. It's not specifically a mentalization measure. It actually has 100 items, 100 different items that describes the child's behaviors, the therapist's actions, and their interaction. How the mentalization score is generated is they gave these 100 items to experts in the field who were experts in mentalization, and they Q-sorted these items and said this would be a session that would adhere to mentalization practices, Q-sorting the items and showing items that are most mentalization adherent according to their theory. So the most mentalization adherent items are the ones that are on this scale. Therapist verbalizes internal affects, comments on changes in child's mood, makes links. Therapeutic interaction items that show sensitivity to the child's level of development, accommodates to the child's needs. Child shows curiosity. Child is willing to communicate with the affect and engages in spontaneous play. There are other items that are correlated with the mentalization adherent session. These are the most prototypical items. So we use the child process Q set, and we had this most prototypical mentalization adherent session. And we correlated our sessions with that theoretically adherent session. And we got a score that showed us how mentalization adherent our sessions are. In terms of how we selected the sessions, in the first study that I showed you, in this study, we took 2 consecutive sessions from each phase of treatment, sessions 1 to 10, 11 to 20, and so on. In the second study that I showed you, we actually used all the sessions from all the children.
Thank you, Sibel. We have 2 more questions. This first one is from Sandra Ruffman, and she asks, how much is due to the child's commitment to spontaneous play, and how much is due to the therapist's ability to reflect the child's affect? Is a lot not hidden through just using mentalization?
Unmuted.
Again, that's a great question. I can't, we can't say it's only the child or it's only the therapist. That's why we're assessing both together. But the sessions that I showed you in the beginning, they pertain to the beginning of treatment. So it's more independent from therapist interventions. But obviously, over the course of treatment, one of the therapeutic aims is to help children engage in more play and to be more spontaneous. So it becomes a combination of both therapists' behaviors as well as child behaviors. that help children spontaneously play. It's a dyadic space. Play is a dyadic space, and the more the therapist helps the child, the better the child is able to play and hopefully develop that play capacity. So yes, underneath the child's capacity to play, there is therapist facilitation, and it's the joint effort that helps the child play. So that's why we're assessing both together. And yes, it is the therapist's, we find in our studies that it is the therapist's mentalizing functions that promotes, that predicts affect regulation. So it's most meaningful to assess both constructs together.
Thank you. Francesca from before also thanks you for a very clear answer for before. And we have one last question here from Leila, and she asks, I wanted to know, did you notice that the therapy is more effective when you use this coding? And if you notice more effectiveness in therapy in a specific age group or specific problem?
Unmuted.
Let me clarify the first question. When she says, is the therapy more effective when I use this coding? Does she mean if the therapists are trained in this coding, is the therapy more effective? Is that what she means?
Yes, Leila says yes.
Yes, Leila says yes.
Okay, yes. So this is, from the therapists who are trained on this. This is the feedback that I get from them, also from my clinical work. Yes, it gives you a really good clinical tool to track the child. So you know how to, how to track the child's affect transitions, how to track different strategies of affect regulation, what the child responds to. It gives you like a very good clinical tool to understand the child's affective world. And it trains you to look for specific affective markers. So I would say from my experience and from the experience of therapists who are trained in this, that it helps you better attune to the child's emotional world. Absolutely. Could you repeat the second question for me, Alex?
Yes, of course. If you notice more effectiveness in therapy in a specific age group or specific problem.
Unmuted.
It depends on how you define effectiveness, but if we're talking about affect regulation, in our studies, we control for age. So all these analyses, you will see that gender and age, we control for them. In terms of diagnoses, we find that improving affect regulation contributes more to gains in externalizing problems. This may be because externalizing children have more deficits in affect regulation, like in the two videos that we showed. So improving affect regulation is more critical, could be, I would say, for externalizing children, whereas internalizing children may need help with, other kinds of deficits. Even though they also benefit from affect regulation, but externalizing children show more significant gains in affect regulation. So diagnosis does moderate that. In terms of age, I haven't seen in my studies if, there's a difference in terms of effectiveness according to age. But, it's still, I don't have a very large sample, so as the sample size increases, it's surely a variable that I check for to see, if older children benefit for or younger children benefit for from this sort of treatment. But in my studies, I haven't found a difference according to age. For diagnosis, yes.
Thank you, Sibel. That's actually all the I was gonna say that's all the questions we have, but we just got a new one. So from Merv, we have here, at the beginning of the seminar, we said that we first do segmentation if there is a play or pre-play or no play. I wonder how can we evaluate affect and affect regulation in pre-play and no play modes. And I also wonder what happens if during the session play stops for a while and the child enters in a no play mode.
Unmuted.
Great question. This instrument, children's play therapy instrument, only rates affect in play. We look at child's affect regulation characteristics in play because, it's again a psychodynamic assumption that, the play space is the space where the child brings most of their internal world. And we want to see the child when they're most engaged in expressing themselves. And also developing affect regulation in play is a significant capacity for children. Research shows, developmental research shows that when children are better able to regulate affect in play, children below the age of 10, it's significantly associated with adaptation, coping, friendship skills, etc. So children's play therapy instrument only assesses affect regulation in play. To answer it, is it possible to use these items out of play? Possibly. I mean, the items are very psychodynamically based, and it is possible to observe these also outside of play, but this coding is specifically generated for play behaviors. What happens when play stops? So just to answer your question, we don't code for affect regulation in non-play, pre-play, or interruption. We only code for play segments of the session with the CPTI. With another instrument, it might be possible to code affect regulation. What happens when play stops? There is an interruption, or, child might go to non-play. Whatever the child does, that's coded. And when the child starts playing again, we code the next segment for affect regulation. So each play segment gets coded on its own. And then you can choose, according to your study, you can choose to use all the play segments, take their average, or you could choose the longest play segment of the session, thinking that it represents most of the session. It depends on your research interest and research question.
Thank you, Leila. You actually also have a thank you, Sibel, I meant, but you also have a thank you here from Leila saying millions of thanks, very informative session and very clear answer. And Nicolas is signaling me here that he has a question. So let me see if I can get to Nicolas here. Nicolas. Nicholas, are you writing your question, or did I miss it? I don't see any question from you here, so maybe you're still writing it. I can read you, yes. I can't. Oh, maybe you can talk now. Try now.
No, you can hear me too.
Yes, I can hear you.
Okay, well, so I'm sorry because I was late in the seminar and I was all the time with a doubt in my mind if we were speaking about the Hamburg tool. So if I understand well, what she showed was a part of a more complex tool that is the CPTI of Camber, and only the part of the affect, of assessing affect. This is right, what I'm understanding?
Unmuted.
Yes, it's right. As you'll see on this slide, it's a very comprehensive measure of codifying play behaviors in the session. So it has many other items and scales that pertain to other play behaviors.
Okay, thank you about that. So I was aware of this item and thought that it was really complex to codify the whole structure, but also thought that it was really useful to see the structure of play, the whole instrument. So I doubt about if there is any way of being trained in the whole instrument.
Unmuted.
Actually, I just show you the affect items of the instrument just for the purposes of this webinar. In my study, we actually code the whole play segment using all the scales, so we code for the category of play, meaning, is it art? Is it symbolic play? Is it more tactile? How much the child is able to sustain play, facilitate play, where the child plays? Is it, are they using the whole room, a little bit of the room, meaning this sphere of play? We code for how the child talks during play. Do they talk about the play, or do they, narrate the characters, the social characteristics between the play characters, or the social relations with the therapist during play? The coping strategies, I mentioned obsessive defenses that would be coded in this instrument, or awareness of being in play. So all those can be coded, and we code for all those. We don't just code for affect, and we use it comprehensively. I just, for the purposes of the webinar, I only showed the affect items. In terms of training, yes, you can be trained. Saralee Shazan trained me. So it's possible to get training from her.
I'm sorry, it's possible to be trained for.
Unmuted.
Sorry.
I didn't understand.
You didn't understand which part?
To be trained by Shazam.
You can be, yes. So you can be trained, or I'm also as trainer trained me. I can possibly give trainings, so it can be organized.
I have two more little questions, if I have time.
Unmuted.
Alex, do we have time?
Maybe we can ask you to try to fill into one bigger question. Is that possible?
Hey, yes. Which is the amount of time of coding? How many? I'm sorry about my English. How many items, and which is the amount of time that you have to for coding one page with all the whole tool?
Unmuted.
Okay, so it has many items, but the items cohere well together. So once you watch the session and segment it, it would take, depending on the child, 30 to 45 minutes to code one session. I'm not sure if you're asking also about the training, how long the training is. It would be at least a 3-day training and then coding 10 sessions for reliability.
Thank you very much. You are really useful. Thank you.
Unmuted.
Thank you, Nicholas. And we actually don't have. Sorry, we actually don't have any more questions, Sibel. So I'm wondering if you have any final statement or reflection you want to leave us with.
Unmuted.
Thank you so much for listening, for participating in this webinar, for the inspiring questions. It was a pleasure, and I hope I was able to convey some exciting research.
You certainly did. Thank you so much, Sibel. And I want to tell everyone who's here that the webinar itself was recorded and will be online on SPR's Vimeo page. So it's free of charge. You can go to SPR's Vimeo page and you can see this full webinar recorded again. Thank you so much, everyone.
Unmuted.